Hi guys, today's topic about surgical anatomy of surgical anatomy of thyroid. So this is very important topic for thyroid surgery. Now first is development. This is primitive pharynx and these are the pharyngeal arches. So this fifth arch form the ultimobranchial body. So this is neural crest cell origin. So ultimobrachial body coming from here and primitive pharynx form the endodermal thickening at the fourth week of gestation. This endodermal thickening is called thyroid enlarge, or you can say midline thyroid diverticulum. So this primitive pharynx form the endodermal thickening at the level of the tongue development that lead to thyroid enlarge, and that is midline thyroid diverticulum. And this ultimobrachial body coming from the neural cluster cell from the fifth pharyngeal arch disappearing. These both combine form the at fourth month completion of the thyroid development, forming the thyroid. So this is the thyroid gland. Okay, so this part here is elevated. We have this ultimobrachial body and this midline thyroid diverticulum is fused. It's called tubercle of Zuckerkandal. So this tubercle of Zuckerkandal forming the fusion between ultimobrachial body and midline thyroid diverticulum that develop the thyroid. This ultimobrachial body forming this part is secret the forming the para follicular cells which secrete the calcitonin, which is the antagonist of the parathyroid hormone. So this parafollicular cells coming from the ultimobrachial body, and importance of these parafollicular cells are they are leading to medullary thyroid cancer. So in medullary thyroid cancer, you are doing calcitonin level because of this origin is coming from parafollicular cells. Rest of the thyroid cancer like papillary, follicular, anaplastic is coming from the follicular cells, and these are the follicular cells coming from the midline thyroid diverticulum. So development of the thyroid is coming from thyroid enlarge or midline thyroid diverticulum and ultimobrachial bodies. So this is the thyroid development. During development, what happens? During development, what happens? This is the tongue level. You have to remember this thyroid is developed before the development of the trachea, larynx and tongue. So This is the tongue level. This is imaginary tongue because it is not developed till now. And here is the copula of the tongue, and here is the tuberculum impar, and this is the foramen cecum. So this thyroid developed from this foramen cecum level at fourth week of gestation, and this thyroid is descent and reach in the final position in the neck. Reach in the final position of the neck at the seventh to eighth week, and this thyroid is fully developed at the 10th week, means about 3.5 to 4 months. So completion of the thyroid is at the 10th week or 3 to 4th week. This is the first endocrine gland which is fully developed. So this is the first endocrine gland which fully developed at the and first to develop in the embryological life. So this thyroid reached in the position at the 10th week. Before that, if this track is patent, sometime mostly it disappear by the 10th week. This track sometime intact form lead to thyroglossal duct cyst. So first clinical application is if this tract is intact, that is lead to thyroglossal duct cyst. Sometimes this thyroid is not descent and lead to abnormal position like here below the tongue, behind the tongue, prelaryngeal position, and below the pretracheal position. So this is called, where this descent stop is called ectopic thyroid. So failure of thyroid lead to ectopic position of the descent. In the line of the descent is called ectopic thyroid tissue. What happens if this upper part is disappear of this tract, and this may connect to one lobe or isthmus, this like pyramidal in shape, and this may attach to here. This is called, third application is called pyramidal lobe. It's called pyramidal lobe. So this can be present into 10 to 20% of the cases during thyroid surgery. Sometimes what happen, you remove this thyroid but left this pyramidal lobe. So that is may lead to recurrence. So remember, always search for pyramidal lobe. Fourth, and always search for ectopic thyroid tissue also. You should thorough investigate the thyroid cases. Fourth is, if this thyroid leading to connect this foramen cecum via fibrous band. This is the fibrous band, and this fibrous band is called, what is this called is levator thyroid glandularis. Glandularis. So this band of fibrous band is called levator thyroid glandularis. So here during development, you have to search all these things during thyroid surgery. So what is the clinical application of the thyroid development? Thyroglossal duct cyst descent during forming the endothelial lining tract, that is called thyroglossal duct cyst. Second, ectopic thyroid tissue. If this descent failure in between the normal position of the thyroid and foramen cecum is called the ectopic thyroid tissue. Third is pyramidal lobe. In some cases, one lobe or one extra tissue is attached with the one of the lobe or isthmus is leading to pyramidal lobe. It presents in 10 to 20% of the cases. What is levator thyroid glandularis? It is a fibrous vein between the cecum and thyroid gland. So this vein is intact called levator thyroid glandularis. So this is all about development. Now comes about thyroid gland. This is the thyroid gland. This is the trachea, and this is the larynx. So this is the thyroid gland. This thyroid gland is what why this is thyroid gland is called thyroid, because this is the thyroid coming from thyros. Thyros is a Latin word that means shield. So this is shield like structure coming from Latin word thyros. It is butterfly shape. You can see this is like a butterfly shaped gland. Weight of this gland is about 20 to 25 gram. Weight of this gland is about 20 to 25 gram. Color is reddish brown color. Color of this gland is reddish brown because it's having high vascularity. Weight of this gland may increase in the pregnancy, lactation, and puberty. So this weight can increase in pregnancy, lactation, puberty. Normal weight is more in female than the male. So weight is more in the female than male. What is dimensions? So length is about 5 centimeter, width is about 3 centimeter, anteroposterior is about 2 centimeter. So 5, 3 into 2 is the normal dimension. 5 length, 3 centimeter is the width, and 2 centimeter is anteroposterior diameter. So this is the normal dimension of the thyroid gland. Now comes this thyroid extend. This thyroid extends from vertebral level C5 to T1 or T2. Normally up to the T1 level. And this thyroid, if you see on tracheal or laryngeal level, extends from mid level of the thyroid cartilage up to the fifth tracheal ring. Up to the fifth tracheal ring. So vertebral level C5 to T1, and from mid level of the thyroid cartilage up to the fifth tracheal ring. And this isthmus is situated between tracheal ring, T2, T3, and T4. So this extends from T2, T4 tracheal ring. This isthmus. Isthmus dimension is about 1.25 into 1.25 centimeter. Okay. If you see this gland three dimensionally, I am taking one lobe. This is the isthmus. This is apex, and this is base of the thyroid lobe. If you see, this is median is like this, and here is the trachea. So here is the trachea, and this is like this. So this forming three borders. What are the borders? This is lateral border, lateral border, and this is the posteromedial border, posteromedial border behind posteromedial border, and this is the anteromedial border. So this thyroid lobe having three border: lateral border, posteromedial border, and anteromedial border. In between this anteromedial and posterior medial border, this part which is attached to the trachea or esophagus is called median surface. Medial surface. This is the medial surface. What the left is anteriorly. This is the anterolateral surface, or you can say lateral surface, and behind. This is the posterolateral surface. So three border: anteromedial, posteromedial border, and lateral border. In between there are three surfaces: medial surface, anterolateral surface, and posterolateral surface. These are the surfaces. While we talk about this having superior border isthmus, inferior border, and this is isthmus. So this is superior border, inferior border, and this is the anterior surface, and this is the posterior surface. So this is about this dimension and borders of the thyroid gland. Now this supply, blood supply. Blood supply of this thyroid gland coming from the one is coming from superiorly. This is called superior thyroid artery. This superior thyroid artery is coming from the first branch of the external carotid artery, and this supplying the most part of the gland. About this is 60% supply of the thyroid gland. One artery is coming from below, that is called inferior thyroid artery. This inferior thyroid artery is coming from the thyrocervical trunk, that is from the branchial trunk, branchial artery. So this thyrocervical trunk giving the inferior thyroid artery, and this external carotid giving the superior thyroid artery. And this superior thyroid artery divided into anterior and posterior branches, and this inferior thyroid artery divided into the descending and ascending branches. So these two branches sometimes having anastomosis and supplying some part of the superior parathyroid gland from behind. Another artery which is coming from below, present in 10% of the cases. This artery is called thyroid ema artery. This artery can present into 10% of the cases. It's coming from directly from brachiocephalic artery or aortic arch. So three arteries: superior thyroid artery and inferior thyroid artery. Mainly two arteries. One 10% of the cases is thyroidema artery is also coming. Now vein. Vein is coming from the IGB. Two veins are coming from the IGB. One is along the, this is IGB. One is coming along the this superior thyroid artery. This is called superior thyroid vein. One is coming separately, individually. That is middle thyroid vein. That is coming from IGB. And one vein which is coming below, and that forming plexus. This is the inferior thyroid vein, and this inferior thyroid vein is coming from the brachiocephalic vein. Brachiocephalic vein. So there are three veins: superior thyroid vein, middle thyroid vein, and inferior thyroid vein. This inferior thyroid vein forming the plexus in between the two lobes. And this inferior thyroid vein and middle thyroid vein sometimes having a small vein in about 10% of cases between the inferior thyroid vein and middle thyroid vein is the Coker vein, Coker or Kocher vein, Coker vein, Coker vein. So mainly three vein are there: superior thyroid vein, middle thyroid vein, and inferior thyroid vein. And mainly two arteries are there: superior thyroid artery and inferior thyroid artery. But in 10% of cases, you can find thyroidema artery or one is Kocher vein is present. So this is about blood supply. Now lymphatic drainage. Lymphatic drainage. Lymphatic drainage of this thyroid is coming from the prelaryngeal lymph node, pretracheal lymph node, paratracheal lymph node, and that ultimately goes into the second, third, and fourth level of the lymph node. So pre-laryngeal, pre-tracheal, paratracheal lymph node going into the third, fourth, and second, third, and fourth. During dissection, if there is malignancy present and lymphadenopathy is present, then you have to dissect this node with this central compartment, as well as you have to remove the second, third, and fourth lymph node during thyroid malignancy. So this is the lymphatic drainage. Now ner- nerve supply. Nerve supply. So sympathetic supply of this thyroid is coming from the middle and inferior cervical ganglia. So this sympathetic supply of this thyroid is coming from the middle or inferior sympathetic cervical ganglia. And this is not secretomotor. What is secretomotor? Because endocrine is directly handling by the thyroid stimulating hormone from the pituitary gland, not handled by sympathetic secretions. Second is parasympathetic supply. Parasympathetic supply of this gland coming from the superior laryngeal nerve, mainly external branch, and inferiorly recurrent laryngeal nerve. So secretomotor fiber is not present here. That is parasympathetic supply to the thyroid gland, because these endocrine glands secrete by the thyroid stimulating hormone. So this is about nerve supply. Now some important relationship of this thyroid. This is the thyroid gland, and this parenchyma is like this, and this parenchyma is adherent with the true capsule. True capsule covering this parenchyma of the thyroid gland is formed by the connective tissue. Connective tissue. But this pretracheal layer, if you dissect the thyroid, enterally skin, superficial cervical fascia, and deep cervical fascia. So uppermost layer of deep cervical fascia is pretracheal layer. Pretracheal layer. This pretracheal layer form the false capsule. this pretracheal layer of deep cervical fascia forming the false capsule, and this false capsule forming here one tight band near the cricothyroid muscle. That tight band you have to dissect during surgery. That tight band is called Berry's ligament, or you can say ligament of Berry. So this tight connection between the trachea and thyroid is called Berry's ligament, and this Berry's ligament helps during movement of the thyroid gland during deglutition. So this is the Berry's ligament, and you have to sharply dissect this Berry's ligament because near this you will face the recurrent laryngeal nerve is there here in the tracheoesophageal groove. So this is the important part. Now some relationship of this thyroid gland. Very important for the dissection of the thyroid. That's why these are relationships is very important. This is the thyroid and this is the trachea. One nerve is coming superior laryngeal nerve that forming the two branches. One is internal branch, and second is external branch of superior laryngeal nerve. This external branch supplying the cricothyroid muscle, and while this internal laryngeal nerve going into the through thyroid membrane into the above the vocal cord sensory supply. So this external branch is nearby to the this pedicle, thyroid pedicle. So this external branch supplying the cricothyroid. If you cut this during surgery, patient may lead to decrease in the pitch power decrease. So pitch will decrease. So in singer, if you are doing the surgeries, you have to take care, and everybody you have to take care of this nerve. In about 90% of cases, you can easily find out this external branch of the laryngeal nerve. So there will be loss of tension. This tension is because of cricothyroid muscle that is supplying by the external branch of the superior laryngeal nerve. And how to identify this is there is two classification. One is called Jones triangle. This Jones triangle is also called sternothyrolaryngeal triangle. Sternothyrolaryngeal triangle or Jones triangle. This is formed by the here is the midline. Here is the strap muscles, superiorly strap muscles, and laterally superior fold and pedicles. So laterally superior fold and pedicle, medial midline, and above is the strap muscle forming a triangle. This triangle is called Jones triangle. So laterally superior pole with pedicle, superiorly strap muscle, and this is the midline. Forming this triangle is called Jones triangle. And content of this Jones triangle is this nerve. This already coming. This nerve is which floor is formed by the cricothyroid muscle. So this is external branch. It's inside this triangle. This is called Jones triangle. Another important point here, if this nerve, this is the artery, and this nerve external branch is most of the time, in 25% cases, most of the time coming in between the 1 centimeter of this superior pole, and sometime in 25 to 30% of cases this is coming above the 1 centimeter, and about 15 to 20% of cases this coming below 1 centimeter of this superior pole. This is the label. So this classification is called Cernia. Cernia classification. So class 1, second A and second B. This is above 1 centimeter. This above 1 centimeter is coming about 25 to 30% of the cases. And within 1 centimeter, equal to 1 centimeter, is crossing this artery is about 48 to 50%. And below this level, coming at the below the upper pole, less than 1 centimeter of upper pole, below the 1 centimeter, and this is about 15 to 20% of the cases. So most commonly this crossing within 1 centimeter of the upper thyroid pedicle, this is most common. MCQ can be asked here. So two things are there: Jones triangle and this Cernia classification. Another for recurrent laryngeal nerve are two triangles. This is the inferior thyroid artery, and this is the common carotid, and this is the trachea. So this is the common carotid artery. This is inferior thyroid artery, coming like this. So this here is one nerve is coming in the tracheoesophageal group. This is called recurrent laryngeal nerve, coming from the subclavian, below the subclavian from the right side and below the arch of aorta on the left side. So this recurrent laryngeal nerve forming here one important triangle is called OH Weir's triangle. That triangle formed by this midline, this. Okay, I will draw this again so that you will understand better. This is inferior thyroid artery, and this is the common carotid artery, and here is the nerve going in the tracheoesophageal group. So this triangle is OHP triangle. Superiorly, there is inferior thyroid artery, laterally common carotid artery, and inframedially is the recurrent laryngeal nerve. This triangle is called OH-Weir's triangle. So one of the boundaries formed by the recurrent laryngeal nerve. Another triangle that I follow during surgery is the Lowry's triangle. What is Lowry's triangle? It is midline is formed by the trachea or esophagus, laterally carotid, and this is the inferior thyroid artery. In between that, you can trace this recurrent laryngeal nerve. So this triangle is called Lowry's triangle. So laterally this is, I will draw it separately. This is carotid artery. This coming from thyrocervical trunk is the inferior thyroid artery. And this is the midline trachea. And this nerve is going like this. So in between inferior thyroid artery, midline and common carotid, you can trace this nerve. So it is easy and you could not damage this recurrent there because it's not forming any boundary. So between trachea, common carotid and inferior thyroid artery, you can trace this nerve below from the suprasternal level. So this is called Lowry's triangle. Now posteriorly, if you see, suppose this is the posterior part of the lobe. Here are four parathyroid glands, commonly four parathyroid glands. Superior parathyroid, inferior parathyroid. Inferior parathyroid develop from the third pharyngeal pouch and superior develop from the fourth pharyngeal pouch. And this is more descend in the neck because of the thymus origin from the same third pharyngeal pouch. So this comes more inferiorly than the superior during descent, during development. And this superior parathyroid and inferior parathyroid in 90% of cases supply from the coming from the inferior thyroid artery. So during dissection of the thyroid, you have to take care and you should not devascularize these branches of the parathyroid. You should dissect and preserve these branches of the parathyroid supply. Otherwise, patient may lead to hypocalcemia because of decrease of the PTH level. So this parathyroid in 10% of cases, or this 100% inferior parathyroid supplying by the superior inferior thyroid artery, while this superior parathyroid sometimes supplying from the branches of anastomotic branches between the superior thyroid artery and inferior thyroid artery in 10% of the cases. Most of the things in the thyroid surgery is the 10%. And beauty of this parathyroid gland is you can implant if patient develop hypocalcemia, you can implant this parathyroid of any family member of anybody without any graft versus restriction to anyone. You have to take patient. Suppose one patient develop hypocalcemia and there is no PTH level is there. So what you can do, you can take one parathyroid from anyone from the family or anybody and implant this parathyroid in brachioradialis muscle of anybody into the this hypocalcemic patient because of the thyroid surgery. And this graft will taken up rate is about 80 to 100%. And during dissection, you can implant this if same patient is there and you can devascularize this and suppose devascularization of parathyroid happens, then you can implant this in the same sitting in the sternocleidomastoid muscle. Sternocleidomastoid muscle means sternocleidomastoid muscle. SCM. You can supply this in the same sitting. In the implant, you can make 20 or 30 pieces of this parathyroid and implant this in the sternocleidomastoid muscles. So this parathyroid is important for preservation of this blood supply during thyroid surgery. Otherwise, patient will have more morbidity than itself by the thyroid surgery. So this thyroid surgery is all about dissection. Entirely you have to dissect skin superficial fascia and pretracheal layer of deep cervical fascia. Then you have to dissect it from the thyroid tissue. So this thyroid is ultimately you have to take care meticulous dissection during thyroid surgery, and these thyroid surgery should be done under microscopic vision because you can detect the parathyroid external branch of superior laryngeal nerve as well as recurrent laryngeal nerve. So this is all about thyroid anatomy. Thank you so much.